and didn't want to do a stand-up or something, that would have other people involved, but did want to have the opportunity to answer some of your questions and share what we know about this updated COVID-19 vaccine that is coming. This is a big deal. And the timing of it is such that the announcement is likely to come kind of over Labor Day weekend. And I know that for all of you and for all of us, that timing is perhaps not ideal. And so before that happens, wanted to tell you what we expect as well as what we're planning. And we will share these slides after. So if you follow CDPH on social media, we've already started to do some, coming soon after Labor Day, updated COVID-19 vaccines. And these new, what are called bivalent boosters, as you may know already, are targeted specifically toward the Omicron subvariants, the BA4 and the BA5 that are what are circulating right now. It's the first time we've had an updated COVID vaccine since the vaccine rollout. So here's where we are. Step one, in terms of us being able to go ahead with this, happened yesterday. Yesterday, the FDA authorized these what are called bivalent COVID vaccines for use as a booster dose. They authorized both Moderna and Pfizer, and we'll talk about that. So that's step one. These are the booster packages for both Moderna and Pfizer. We've already started doing, the education folks need to know about, you got to store this one frozen and ultra cold and distribute and all of that, but just sharing that these are coming as multi-dose vials. They are only meant for use as booster doses. Step two is happening today. So the FDA has to give it the green light and the CDC has to give it the green light. So the CDC's Advisory Committee on Immunization Practices, the ACIP, meets today to discuss clinical considerations and make recommendations. So for example, we've already been getting the question, if I just had COVID, like me, should I be getting this updated vaccine right away or should I be waiting? We don't have the answer to that yet because the ACIP, these are the kinds of things that they make the recommendations and the CDC weighs in on. So there are still a few outstanding questions that we anticipate will be answered with this. So they're meeting today all day, 10 to 5 Eastern. And that is available online if anybody wants to watch. But the vote is at 4:30 Eastern. If they're not ready to vote, though, they've also held tomorrow morning, 10 to 12. So the earliest I think we could see a vote from ACIP is later this afternoon. The latest would be tomorrow midday. So that's step two. And then step three is the CDC director, Dr. Walensky, gives the final approval, vaccine ship. And that could happen as soon as tonight. It could happen over the Labor Day weekend, pending a little bit
in progress
how the ACIP meetings go. So why do we need an updated COVID vaccine? So this new vaccine is called bivalent, bi like two. It's a mix of two versions of the vaccine. It is both a boost of protection against the original coronavirus strain, as well as newly protecting against BA4 and BA5. More than 95%, and in fact, I'll show you it's now more than 99% of cases in the US, in Chicago, in Illinois are caused by the BA4 and BA5 subvariants. While the vaccines we've been using all until this point were designed for the original coronavirus strain from 2019, 2020. So this vaccination really could, and I expect it probably will, begin next week, like right after Labor Day, most likely. It's really different from the boosters that have previously been offered. And I want you to understand that this vaccine gives us a chance to try and get ahead of the virus. It helps us protect individuals from the variant that is currently circulating in the US. My biggest worry was once there was a decision to make an updated COVID vaccine, my biggest worry was that by the time an updated vaccine was available, we wouldn't still be at BA4 or BA5. We'd be on to BA9 or BA10 or some completely different variant, and we wouldn't see a really good match. This is the best possible match. And so we very much are going to want people to get this updated vaccine now, not to wait 3 and 4 months, but right now is when there is a beautiful match against the circulating strains. And it's kind of like every year we make a flu vaccine. The flu vaccine is made based on the scientists' best guess of which strains or variants of flu are circulating. And the flu vaccine performs differently each year based based on how good the match is. That's what you'll hear us say. If it's a year that there's a very good match, the vaccine strains that we've chosen to make that year's flu vaccine are a really good protection. If it's not a very good match, it means one of the strains of flu isn't covered as well, and we see more breakthrough flu infections. So this is the same idea. The match couldn't be better, and really are hopeful that people will choose to get this vaccine. So here's the really good news. Everything is still Omicron, and it's nearly all BA4, BA5. So this is across the whole Midwest. You can see this is through really this week. 99.7% of all of the COVID strains are either BA4 or BA5. There's just 0.3% that are still one of those old BA2s. That's amazing for this vaccine. Match couldn't be better. And across the US, it's the same thing. So the dark green is the BA5, the blues are the BA4, and across the whole country, 99.8% right now are BA4 or BA5. So why do we need this vaccine? We know that the original boosters, the original vaccines and boosters were providing great protection against hospitalization and death for Chicagoans. If you follow along on Facebook, these are available at chicago.gov/COVID-. We update them every week. And just on the left, these are COVID hospitalizations just in Chicagoans, and on the right are COVID deaths just in Chicagoans. And every single week we update, and you see here that the red line are unvaccinated Chicagoans. And you can see that huge spike in January where the great majority of people getting hospitalized and dying disproportionately were those who were unvaccinated. But then the light blue are those who were fully vaccinated, and the dark blue are those who are boosted. So you see that getting boosted also had significant improvement for protecting against hospitalization and especially death. Even in the worst of the early Omicron surge, you see that those who were boosted had really very low rates of death. And so since the Omicron variant became dominant in Chicago, unvaccinated people have been more than 3 times as likely to be hospitalized and almost 6 times as likely to die as those who have been boosted. So getting an updated COVID vaccine gives you an additional boost. It will definitely help continue to grow that protection against hospitalization and death. But we are also hopeful that it will have significant improvement against some of these breakthrough infections as well. So where you look by age group, and you can go on the website if you want to sort this out by different age groups or other, especially for people over 65, you see how significant that risk is for unvaccinated versus vaccinated versus boosted. And the older you get, the more of a thing this is. So especially for people who are older, have underlying conditions, they're the most important to get this updated vaccine. But if more people can get the updated vaccine, the hope is that that also will decrease the risk of as much infection right now, which in turn will decrease the risk for future variants is the hope. So I just wanted to share a very little bit of some of the science here, and if folks have questions, I'm happy to answer it. The first, back in June, both Moderna and Pfizer presented data to the FDA, human data, with the first version of the bivalent vaccine that they had made. That was a combination of the original as well as BA1, the earliest versions of Omicron. And the safety data was excellent. These were studies of hundreds of adults. And the safety data was really good, didn't see any problems, anything different in terms of side effects from what we've seen with vaccines all along. And the efficacy data was also quite good. However, the decision was made at that time not to give a green light to the BA1 because the virus was mutating so quickly. And they went and said, nope, tweak it a little bit, come back, get one that protects against BA4 and 5. And so The vaccine that is now being authorized, or that just got emergency use authorization yesterday, is a tweaked version of that one that went through the trials back in June. This is a preprint, so I've got the reference down on the bottom if you want to look it up. I expect it'll get formally published soon. But the reason I put it up here is it pulls together 8 different studies that were comparing how well did original vaccine versus ancestral is what we call it, if it's a version of a vaccine against the ancestral, the Wuhan version, versus a vaccine that was made for a variant. And so whether these were versions of vaccines that were made for Beta or Delta or Omicron, this meta-analysis pulled together how much more effective were vaccines that had been changed to better protect against the way that the spikes have changed. BA4 and BA5 have the same kind of spike. And so what you see here is the higher these little boxes are, the better. Higher means that this shows how much more of an increase do you have basically in the antibodies. And so we know when people get a booster, they get about an 11-fold increase in their antibodies, in their level of protection. And so this on the left shows that whereas an ancestral strain it gives, 1 is sort of considered like that is how much protection. It would be an 11-fold increase, but it's a one-time increase. When you give a variant, a version of the vaccine against a variant, instead the average is 1.5, meaning about a 50% higher level of antibody protection when you've got a vaccine that is a better match to the variant. And then on the right, the difference is, are you testing the vaccine against, for example, this is made for BA4-5 and you test it against BA4-5, which is on the left, that match vaccine. It's about 75% higher versus a non-matched, which is when you've got an updated vaccine, but maybe you're giving it against an earlier version of Omicron. And so the idea is, the reason the decision was made to do, the expense to do an updated vaccine was that the protection in humans is expected to be quite a bit higher. And the better the match, the higher it is. And so this is just some of the information that the advisory panels to the FDA were looking at. So here's what we know so far. I've got to put a little caveat. It's possible anything could change with the ACIP recommendations, but I don't expect it. So who can get this updated COVID vaccine, the bivalent booster? Anyone who has completed their primary vaccine series, meaning way back in the day or recently, if it's been 2 months, they've gotten 2 doses of Pfizer, 2 doses of Moderna, or 1 dose of J&J. And it does need to be a booster because the dose here is a little lower, and you've got to get the original version of the full protection before you can get the booster. So that is important for people to know. Does it matter whether I got a booster in the past? No. As long as you received a primary series, you are eligible for an updated COVID vaccine. So if you're somebody who got your last booster 3 months ago, you're eligible and recommended. If you're someone who never got a booster, you're eligible and recommended. When can I receive my updated COVID vaccine? At least 2 months after receiving your most recent vaccine. So if it's been 2 months since you either finished your primary series or got any of that older booster, you are good to go. If you just got a booster 2 weeks ago, you should wait 2 months. Are there age limits? The Pfizer updated booster has been authorized, gotten emergency use authorization for anybody over the age of 12, and Moderna for anybody over the age of 18. That is based on the original trials that were done of the Omicron BA1 from the companies. There may be an updated booster for younger children in the future. That is not imminent or on the horizon. The dosage in terms of the total amount is the same as prior boosters, but it's now split between the two types of protection. So Pfizer is a 30 microgram dose, Moderna is a 50 microgram dose, unchanged. When will it ship? So because we've got EUA approval from FDA, technically shipping can start. We saw ancillary supplies already start to ship, and I wouldn't be surprised if we start to see some vaccine shipping even now. We don't want vaccine arriving on Labor Day or over the weekend, so I think most likely it will be arriving on the Tuesday after Labor Day. We do need CDC and ACI approval to be able to start administering. So the earliest we could be possibly administering would be Tuesday, 9/5, but again, a few things still in the air. Can I still get the original booster? Actually, no. With this new authorization, the monovalent, meaning the old version, are not authorized anymore as booster doses. We really want folks to get these updated. So anybody over the age of 12 who's looking for a booster, this is the one that they're going to get. Individuals 5 to 11 can still get the original booster dose. Will it still be free? We've been getting a lot of questions about this. Thankfully, yes. The federal government is providing this vaccine, is providing the needles and the materials that are needed with it. There is no government issued ID or insurance to receive this updated vaccine. My assumption is this is probably the last version of a COVID vaccine that will exist outside of regular insurance approvals, et cetera, just because there hasn't been additional funding allocated. But I was very pleased that this is remaining entirely free to consumers. And we have not received additional new funding for rollout, but we are using our regular federal immunization funding, tying it to what we do for flu, et cetera, and happy to answer questions if you have it. So let's talk Chicago. Given that we are expecting anyone over the age of 12 who has completed their primary series to be eligible for this vaccine, that means about 1.8 million Chicagoans would be eligible. About 77% of the age 12 and up population in Chicago have completed their primary series. So that's how many, that's our universe of who could get this, this vaccine. If we look by age here, you see this is just right off our dashboard. So the left are the percentage of Chicagoans of different age groups that have completed at least a first dose. That middle are those who have completed a primary series, and the right are those who have previously received a booster or additional dose. So we're it's that middle group, those who have completed their primary series. So you can see, for example, those in their 50s, 87% of Chicagoans are eligible for and should get this updated vaccine, as compared to 73% of 12 to 17-year-olds. So in terms of the Chicago vaccine allotment, we have already been enrolling and setting up for initial distribution healthcare providers that serve higher risk patients and priority providers. We are hearing there will not be prioritization recommended at the federal level. So we're not going to be doing this only people over 65, only people over 50. Obviously, the groups of highest concern are older Chicagoans. So we are prioritizing making sure people in long-term care, people in hospitals, people getting cancer care, senior centers, et cetera, are getting vaccine first. But we are expecting that everybody over the age of 12 will be eligible from the initial rollout. This is partly because the federal government nationwide has told us they anticipate being able to ship about 20 times more vaccine per week than they could in the initial vaccine rollout. So we are anticipating enough vaccine. And again, we've been using numbers here to kind of plan. So this is our initial rollout of the vaccine when demand was highest. And you can see at the peak there in early April, we were averaging about 18,000 doses a day. Earlier around 9,000, you get a sense of sort of what that's been. And so based on previous demand, we feel confident that our allotment is going to meet the upcoming demand. For the first few weeks, it could be a little stretched. Again, we'll be prioritizing the highest risk populations in terms of where we distribute vaccine, but it will be open to everybody over the age of 12. And the feds have said that after the initial allotment, really every week, they're ready to ship more vaccine as we show that we use it. So the city of Chicago has been allocated approximately 150,000 doses of the updated vaccine from the federal government to be shipped up in approximately the first week, probably in two different sort of allotments, but then with more following really quite quickly as needed. So we're expecting those 150,000 doses to go pretty wide, and that's what I want to give you a sense of. We're expecting 90 retail pharmacies to receive vaccine in the first week across the whole city. The CDPH does not control where the pharmacy allotment goes, but we've been in conversations with Walgreens, CVS, et cetera, of course, in parts of the city that have fewer pharmacies, making sure that there's enough vaccine in those settings, et cetera. There are also about 25 healthcare facilities, especially hospitals, that will get it right away at the beginning. Remember, we want to make sure the highest risk people are getting it first, and then additional CDPH locations will be adding more healthcare facilities each week. Pharmacies remain the #1 way that Chicagoans and Americans have received COVID vaccines, including boosters. So we wanted to make sure from the beginning those were available. And we are, of course, following the data. We are prioritizing access for those with more limited access to vaccines. So for example, our Protect Chicago at Home program, which brings vaccine Saturdays, Sundays, Mondays, and Tuesdays right now, morning, afternoon, evening, we'll bring it to your home. Right at the beginning, we will be prioritizing that for Chicagoans who are over 65 or homebound and live anywhere in the city, as well as anyone who lives in the priority zip codes where we still see vaccine lagging or where access may not be as good. As I said, we're already focused right at the beginning on long-term care facilities, senior centers, planning, shelter, jail, et cetera. We've already started provider trainings, more of those to come, and we will be, in terms of messaging, we'll be combining our flu and this updated COVID vaccine media campaign, again, just given some somewhat limited funding for a lot of advertising with rollout. So in terms of numbers here, about in the very first allotment, about 46% are going to retail pharmacies, about 1% are separately going to federal sites, whether that's the VA or some of the federally qualified health centers, and then about 53% to other sites across Chicago. So I think I pretty much went over this. The congregate settings, we're working with CHA. We've got things planned at every DFS senior center. We've worked to make sure that CPS is getting vaccine directly through its contracted vaccine provider. And we will be standing up some larger clinics, our family vaccination clinics at city colleges. We'll be offering the bivalent, the new updated COVID vaccine. We will be offering the original COVID vaccine for anybody who's just now deciding to get vaccinated. We will also be offering the flu vaccine, so people can get both of those free of charge. And we will, because it's been very successful all along, be doing Saturday city colleges. We are tentatively planning our first large clinic where we can do, 800 people, for example, probably at Olive Harvey, Saturday, September 10th, within that first week and weekly thereafter. We are working with the aldermen. We are making sure there's going to be at least one vaccine location and date in every ward. And these are just some of the initial preliminary maps. I wanted to give you a sense of this. We'll be posting these formally on the website once we've got the approval. But you can see on the left, what we call pre-positioning, where there have already been sort of the very first appointments or the very first vaccines ordered. The purple are the pharmacies. You see there are more of them, for example, in the Loop and on the north side. Again, CDPH doesn't control that pharmacy strain. That pharmacy stream, but we've worked to make sure that the ones, especially on the south side, have adequate vaccine available, and then we'll be working to fill in where there are fewer bricks and mortar sites right at the beginning. So you see the pink are the healthcare sites. Again, this is especially hospitals. This doesn't include every single site that will be offering it. So long-term cares, for example, vaccine will be coming to them through pharmacy partners, but they're not shown here because they wouldn't be open to, open to the public. And then on the right is giving you a little sense of the geographic distribution of some of the larger things where we already have sites planned. So added on to that are the aldermanic sites that are already already planned in green. The DFSS senior sites in red. We're starting those actually next week. And then the family vaccination clinics, which are the city colleges. We'll also be supplementing this with places that we've seen really good uptake. Things like Swaporama has been really good for Latinx uptake. And so we're looking at our data, and wherever we've seen good uptake, especially with boosters, we will be continuing that with a special focus on Black and Latinx Chicagoans who continue to sort of bear the brunt of poor COVID outcomes. We are anticipating some disparities, and I want to just talk about that so we can answer your questions. About 77% of those over 12 completed that primary series, but only about 44% have gotten their original booster dose. And I think where we look at national surveys, the concern is that it may be even lower. I'm hoping not, because this really is a better vaccine, but we will be aiming to get that number as high as we can. And racial and ethnic disparities remain a focus. This is off of our dashboards. You can go back and explore it, but I just wanted to emphasize that one of our biggest challenges here is that by different age groups, we see pretty different race and ethnicity uptake, even though there's been a lot of work. And so, for example, this is 12 to 17-year-olds. Again, you have to have completed the primary series to get this booster. And so if we look in 12 to 17-year-olds, 86% of Asian, non-Latinx Chicagoans have completed that primary series, 77% of Latinx Chicagoans, 76% of white Chicagoans, but only 51% of Black Chicagoans. And so there's a smaller pool that would be, at least initially, eligible. So we'll also be encouraging people to, get those first doses now if they have not. And then if you just go by the age 18 to 29-year-olds, you see that difference persists. Higher Latinx, highest Asian, next highest Latinx coverage, followed by white, followed by Black. This is 30 to 49-year-olds. This is 50 to 64-year-olds. And once we get older, this is where we want to see those numbers get as close to 100% as we possibly can, and then those over 65. So I encourage you to explore. But we know, for example, that at home has been a very popular way for Black Chicagoans to get vaccinated, which is why we'll be prioritizing appointments for some of the predominantly Black zip codes or the less vaccinated zip codes. So we will be updating this once the new vaccine gets the green light. The zip codes down on the bottom right there are the zip codes where we've been prioritizing incentives. Those are the ones we'll continue to sort of prioritize for appointments. We still will be vaccinating up to 10 people. So as long as there's one person who is, for example, over 65, we're happy to give updated vaccine to the whole family over 12. But we are going strong with at home because it's continued to be a strong program for us. So this is also continuing 7 days a week, 312-746-4835. And we will be updating our website as well as releasing a formal press release once the CDC has given it the green light. We may do a stand-up next week, depending a little bit where this happens, but just appreciate all of your attention. Happy to take any questions. Just want to very much make sure that all of you have a good understanding of this because it's a big deal, and we don't have all of the resources that we have had previously to lift up all of the, lift it all up as much, I think, with media campaigns. I'll stop sharing and happy to take questions. Thank you.
Yeah, thanks. So if folks have questions, please use that raise hand function at the bottom of the screen, and then we will unmute you and you can ask.
Andy, do you want to call on individuals, or should I just go down the line?
I would go down I'm actually not seeing anything. So.
Okay, I can do it.
Are you seeing?
Yes.
Are you? Oh, huh. That's weird. I can't. So yeah, please do.
Okay. We've got Craig Delamore.
Okay, and thank you very much. Doctor, I'm sure you're aware that when these boosters have been talked about on national media, some medical professionals have expressed a little bit of hesitation about it, and one of the complaints has been that there weren't sufficient human trials for this version. Can you address that? Because that's one of the things that people are hearing. And then I've got a follow-up after that.
Yeah, absolutely. And this is one of the things anybody who's got questions on this, I really definitely want to address. So first of all, there were human trials that were done of an updated bivalent vaccine with the data presented from both Moderna and Pfizer in June to FDA that were done. I think there were about 600 people in the Moderna trial and 800 in the Pfizer. It might have been the other way around, but in that range. And that's where they were able to show the safety data was good, the efficacy data against the original version of Omicron, BA.1, was very good. But there was a decision made, which I agree with, that releasing the vaccine that was very protective against BA.1 was not going to do us a whole lot of good, given that at that point we'd already moved on to BA.2 and getting closer to BA.4. And so the way we approve flu vaccines every year, we don't do a new human trial for a new flu vaccine as long as there's no change in the way the vaccine is manufactured or as long as there's no change in the technology. Instead you do preclinical, which means trials where you're testing, the sera, or you're doing some animal trials. And so those were done and then combined with the human trials for the original trials that included BA.1. So I would say I actually went back and I wanted to really educate myself about this. So I went back and read everything from the original FDA conversation and the advisory group there. For example, I looked at anybody who didn't vote that yes, we should go ahead with this. And one of the doctors there were two people who did not give it the thumbs up. And his concern was not that it wouldn't be safe or that it wouldn't be effective, but that he wasn't sure that the gain protection would be enough for the potential cost of the vaccine. So that was his worry. The other point of concern, I think, was that would the virus have already mutated sort of beyond the updated, beyond BA.4 or 5 by that point, but luckily it hasn't. So I do not have safety concerns. The reasons I showed you that preprint is just, this is exactly what the FDA and ACIP folks are looking at when they make this recommendation. And I'm confident that the trials that were done with the bivalent vaccine against Omicron, just the earlier version, are sufficient. There's nothing that is different, nothing else that is different about these vaccines except a tweak so that it protects better against the spike of BA.4/5 instead of the spike of BA.1.
And then the other question following up. Someone close to me was at a doctor yesterday, specifically about getting vaccinations for going overseas, and said, "What about this vaccine?" And was advised by the doctor, wait 2 months to see how things are going before you take it, which goes beyond the trip that person is in. And said, don't take it before the trip, take it when you come back. And how concerned are you that kind of information, that kind of advice is going to be given out in this circumstance?
Yeah, I am a little concerned about that, I'll be honest. My worry is that if we're waiting 2 months and 3 months and 4 months, first of all, we're in November by then. And based on the way COVID has behaved previously, I do think we would be very lucky to avoid a significant COVID surge. But more to the point, I fully expect COVID to continue to mutate. And if people are waiting 2 and 3 and 4 months, 2 months ago, Omicron looked really different than it looks right now. And the reason I very much want folks to get this now is because it's such a good match for the BA.4/5 that is predominant. And so, we are doing a lot of education with health providers. It's always a little tricky because until we have the final sign off from ACIP and CDC and all of those questions answered, there are, sometimes there are things we have to say, we'll wait and see. But I worry a lot that people may say, oh, I'm just going to wait. And then by the time they decide to get it, either we'll already be in a surge and it'll be too late to get the extra protection, or worse, they will have missed the window for really good protection and the virus may have mutated further. We know that if it's not a perfect match, there is also additional protection. And the reason, actually, this wasn't exactly your question, but it's a good question I've been getting. Why still continue to boost against the original Wuhan strain? And it's because we don't know what the next variant may look like. Omicron is pretty different from the original strain. And the idea of boosting both against the original strain and Omicron is that in case the next variant that emerges doesn't look very much like Omicron, you want to have as much sort of extra protection as you can against all the different ways that COVID has shown up. So that's why the decision was made to both boost against the original and the updated. But you get an 11-time boost in your antibody levels, even if the match isn't perfect. And then the closer the match is, the bigger the increase is after that. And so, time will tell. I'm very interested to see how. I have no safety concerns. I'm very interested to see the sort of real world efficacy here. And we'll follow that just as we have been all along. But no, I hope people don't decide to kind of wait 2 months and 3 months, because getting vaccinated now is the best possible timing for the match.
Thanks, Craig. Now we have Kelly Bauer.
Hi, thank you so much. I had two kind of more technical questions just that I'm getting from readers. One is, I understand there's the 2-month wait after folks' primary and booster, but what about people who just had COVID? Should they still wait or can they get it right away?
Yeah, it's a great question. This is, of course, a question of personal relevance to me as somebody who just had COVID. I am expecting the ACIP and CDC to probably weigh in on this. So we should have a formal answer for that by next week. And if they don't weigh in on it, then we will give a recommendation based on the data that we have. But I'm going to just wait on that one. And it is one of the ones that we are getting a lot. And I want to make sure that we've gotten all the recommendations before I formally answer that. But we'll have an answer for sure by the time of the rollout early next week.
Okay. And then the other one is, I know a lot of pregnant people who have been waiting to get, whether vaccinated or boosted because they want to wait until they're pregnant and far along enough that they can pass on the antibodies to their unborn children. So in this case, with this updated booster, what would be the recommendation there? Should those pregnant people be waiting that way they can pass it on, or should they just get it ASAP?
Yeah, so again, we'll wait to make sure. This is exactly the kind of thing that ACIP and CDC will often weigh in on. These are the charts of, exactly how long you should wait between vaccines and all of that usually comes out. I expect, though, that the recommendation for pregnant people will not be to wait, again, given how strong the match is now. But I will wait, and we'll make sure that in the these are helpful questions for us too. We've been putting together, FAQs just to make sure things are as finalized as possible to be able to turn on the website. So we'll make sure that one is also answered once we've gotten the final weigh in from the feds.
Thank you so much.
Yep.
Thanks, Kelly. Sarah Schulte.
Good morning. Can you hear me?
Yes.
Okay, great. I know you just explained your entire plan, and this is kind of a little bit off of what you answered with Craig. I mean, the booster rates have been obviously so low, and I mean, what really can you do as a health department to really convince people to take this, given the fact that so many people have been hesitant to get the booster, especially since there's such COVID fatigue out there?
Right. So a couple things. One is that, I take more than 6 in 10 older people have gotten a booster, right? And that is, of course, the group that we're the most concerned about, that we continue to see getting the the worse outcomes. But I think there's a couple things. One is we've been working hard to try to build trusted messengers and voices. Again, it's a challenge just because things are moving quickly and we have to have the final approval before we can formally be recommending that folks get this with all the details. But we have, for example, that we've learned a lot, I'd say, over these last couple of years. We know that our COVID core, for example, those are the hundreds of people that we hired who help staff our call line, who do the outreach at events, who do the door knocking. Those are folks who are hired through trusted agencies across the South and West sides and the Chicago Cook Workforce Partnership. That has been our secret sauce in a lot of ways, and we will continue to, not right away the very first week, but those folks will be, we've already started doing sort of trainings and outreach. We also are working to directly follow up with people who we have records of having had their primary vaccine to let them know, it's time for the updated booster and let's get you signed up. And we will also be doing not just waiting for folks to come to us, but we'll be doing outbound sort of calling and outreach, especially for those older Chicagoans, just to make sure people can get vaccinated. We know that getting healthcare providers really on board is critical. We want folks to talk to their doctor, like that earlier question. I'm hopeful that, and I don't expect most health providers to be recommending that people wait, but it is really important that we've answered questions. So just like we're doing this briefing for you, we've been doing briefings and answering questions, sharing more of the science, et cetera, with providers who are typically who patients are talking to first and foremost. And then we're trying to pair this with other efforts. So we were already planning a flu campaign, right? And so wanting to make sure that the updated COVID vaccine is embedded within that. And we've been working with AARP, we've been working with faith leaders, we've been working with, just the sort of trusted partners, again, especially with a focus on those who are older. But I think a lot of it is just trying to break through and have people understand this actually is a different product, right? It's a different and updated vaccine that is a better match. I got COVID because I was on vacation. I feel like if I'd managed to make it another, 3 weeks or so and gotten an updated booster, the chances of me getting COVID probably would have been quite a bit lower. And I'm hopeful that even people who maybe had not chosen to get a booster previously will recognize that this updated vaccine is truly the best protection out there, and it is better protection and different protection than anything we've been able to offer to date. So time will tell, but we've been trying to work with the partners and employers to lay that groundwork, and we'll be looking at our data and adjusting our strategy really week after week.
Then just another question. Are you concerned about the really low numbers of the 6 months to 4 years old of getting vaccinated?
Yeah.
They're really low, and why aren't parents getting their young kids vaccinated?
Yeah, I am. I'll tell you, we're above the national average at 12%, which is nothing to brag about. And there have been a lot of conversations about this. With school coming back in session, we're starting to see, not surprisingly, we're seeing cases, which is no surprise, but we're starting to see some outbreaks, we're starting to see some issues, and it's especially in those little ones, right? It's the preschools and the kindergarten. Kids have more trouble with masks often, and they're not vaccinated. And thankfully, it is true that the youngest kids are the least likely to get seriously ill, but we have young kids who get hospitalized with COVID, and it just makes me sad because I think when a vaccine, I think the youngest kids have suffered from the fact that it took a long time to get to a point where vaccine was available for them. And by the time a safe and effective vaccine was available, I think a lot of, their parents and families had already seen COVID, right? They'd already been vaccinated themselves and or recovered from COVID, and were already in a relative sort of COVID fatigue, paired with the really good news that yes, kids are less likely to get seriously ill. But I am concerned about it. There also, of course, is a 3-dose requirement to get fully up to date with Pfizer. And given that most kids, the older kids, got Pfizer, we saw a lot of people choose to get Pfizer, and 3 doses can feel like a lot for people. So we're still seeing it tick up every week. And I never lose hope. I hope that the reason we call them family vaccination clinics is that when folks come in, to get their updated vaccine, we want to bring anybody in the whole family, any age, up to date, ideally, with either updated vaccines for those over 12 boosters, or the other vaccines, for the kids. But it's been disappointing. I'll be honest with you. And we've done a lot of outreach there too. So I think at this point we're controlling the parts that we can control, and continuing to share the safety data, which is excellent, and make it very easily available, which it is.
Right, and then we have AD Quig.
Hi, yes, can you hear me?
Yes.
Great. Dr. Already, you mentioned a surge a couple times. Can you just give us a sense of what the fall and winter might look like, in addition to what the flu might look like?
Yeah. So obviously I don't have a crystal ball and can't completely predict what is coming. But I will tell you that both of the last 2 winters, we've had notable COVID surges during respiratory virus season, during flu season, during RSV, other seasons. We also, as people, I think, have relaxed against COVID, there's less mask wearing happening broadly. It's been interesting. We've been seeing some of the childhood respiratory viruses kind of spreading in different ways too. I mean, it's amazing if you look at during the height of COVID, we practically eliminated a lot of the regular childhood illnesses just because people were avoiding germs, and that is very much not the case at this point. So, in my ideal world, we would not see a significant surge, but I would be shocked if we did not see at least some surge in COVID infections as we move inside in the fall and winter, and that the timing of that is likely to parallel what we see for flu. The thing I'm worried about is not if a surge comes with Omicron, but if we don't get a lot of uptake of this updated vaccine, we continue to see a lot of mutation, and we have a variant emerge that is really different from anything we've seen previously, right? That's what happened last December, January. Omicron was so different than Beta, Delta, et cetera. And even Omicron BA.4/5 have been different from the earlier versions of Omicron, right? Like prior to Omicron, we thought if you had gotten an Omicron variant, you wouldn't get another Omicron variant. Well, that wasn't true for BA.4/5. We've seen people who got even Omicron back in January and February getting reinfected with BA.4/5. And unfortunately, if you look at our data, between 4% and 5% of our hospital beds in Chicago have patients with COVID in them. And that's very manageable, but it is also not nothing, right? 1 in 20 beds being taken up by people with a positive COVID test. And as always, I worry about the healthcare system, and I worry about the healthcare system the most in the winter. So I can't completely predict what it'll look like, but getting this updated vaccine now in September and October will be the best thing to help keep that surge as in control as we possibly can in November and December. And if people think that it's better, to wait for a surge and then get the vaccine, that is definitely not true based on everything we know now. And is this going to be something where, every fall there's an updated COVID vaccine, just like every fall there's an updated flu vaccine? Possibly. I don't know, but I wouldn't be surprised if that may be where we're heading. But I do know that the data is better than I had anticipated for how good the match is for this updated vaccine. And if people don't choose to take it, we're going to really miss, I think, an important opportunity to get ahead of a likely fall and winter surge.
And can I ask how concerned you are about the availability of at-home or in-person tests, given that the federal program is kind of phasing out?
Yeah, so I'm not hugely concerned. Again, assuming that there isn't a new variant that the tests are not that effective against. I think what we're seeing here is a phasing out of considering COVID different from other illnesses, right? We have really gotten used to, as a country, COVID treatments, COVID vaccines, COVID testing has been free, right? It has been outside of our traditional healthcare system. The feds have really purchased and paid for all of that. And with the decisions at the federal level not to allocate additional funding for COVID, what we will see is a transition, I think, to treating COVID like we treat other illnesses, which means there will still be COVID tests being manufactured, but you'll get them through your insurance more likely. Certainly as a health department, it puts more of a burden on us to make sure that people who are uninsured can still get vaccines, can still get testing, et cetera. We have done some stockpiling, of course, because if we do get a major surge, I want to make sure we're as prepared as we can be. Again, hoping we won't need to use those, but we're paying to store them in case we saw a major problem. But I think it's going to be like so many things are in this country, relatively easy for people who are insured and connected to the healthcare system to be able to access what they need for COVID. And it's going to get harder for people who are not. And I see our job as a health department to do everything we can to make sure that that disparity is as small as possible. And so, we will continue for as long as we possibly can. We will absolutely continue to offer vaccine, especially free, even if folks are not insured. We will have testing available for people who don't have options. But I think more and more, we're probably going to see this move into the way we treat other illnesses, just because the federal response is running out of money. But I'm glad it didn't happen in advance of this updated vaccine, because I think that would have been an additional major barrier.
Great, thanks, everybody. I don't know, do we have time for one more? Or Kelly, your hand is still up. Was that from before?
I apologize. I'm good.
Okay.
All right. Thank you, everybody. If you joined late, we will reach out to me or us, and we will have a recording of this too, so we can share that as well if you want. So
yeah, and we'll
thanks, everybody.
And we'll send the slides around, and we'll be updating the website, just as we're continuing to plan and making sure appointments are available. So really appreciate all of your thoughtful questions and your help in getting the information out. So thanks again for all your time.
Great. Thanks, everybody.
Bye.